Hello, everyone. Thank you for coming. Welcome to this session of NAUTO's 36th Annual Conference. On your attendee screen, you will be able to enter comments and questions in the audience chat. We hope you will take advantage of this opportunity to engage with our speakers. We recognize and thank our Petabyte sponsor, the California Healthcare Foundation. All conference sponsors have virtual booths available during the conference in the sponsors section. At the booths, you can learn more about the sponsors, review materials, request contact, and collect game tokens. We hope all attendees will take a few minutes to visit each sponsor's booth. Now I will turn the stage over to Norm Thurston, NAUTO's Executive Director, who will start today's session.
Thank you, Marin. Good morning and good afternoon to everyone. We're excited to have you here for our first round of breakout sessions on day 2. Today's breakout session is entitled Data Standardization, and the organizer and moderator is Kyle Russell from Virginia Health Information. Kyle, welcome to the stage. Are you ready to go?
Yeah, thanks, Norm. Can you hear me all right?
Yep, sounds great. Let's go ahead.
Great. Hey, everyone. So apologies in advance. I know my voice has sounded better. But nonetheless, I'm very proud to be your organizer today. I'm Kyle Russell. I'm the Director of Strategy and Analytics and incoming CEO at Virginia Health Information. And my job is really just to set the stage, right? I don't have a whole lot to say here up top because from what I've seen for the conference session so far, like the Q&A engagement's really strong. Like we're having to cut a lot of things short and not get to all the different questions. So I want to make sure that we save plenty of time for that. But really my only introductory comments before I introduce our first set of speakers for you all today is that the title is pretty self-explanatory, right? Data standardization and how that played a key component in 3 things I think we all are struggling with in sort of the claims data universe and even broader than that around cost calculations, provider databases, claims versionings. I feel like these are the things that we talk about all the time. We're constantly struggling with, you know, just overall, but particularly with standardization. And I can tell you in Virginia, we have not come up with the best solutions on how to address some of these different things long term. So I know I'm very eagerly awaiting to hear some of the solutions our very accomplished panelists have come up with across the nation. And, you know, I realize that some of these solutions might be state-based, but in general, it's really applicable, right? Like the vast majority of the content that we're going to be going through probably will really well to your state or wherever you are around the world. So our first presentation comes to us from the state of Vermont, and it's going to be around total cost methodologies. And we have 2 speakers with us today. One is Sarah Lindberg, who's the Director of Healthcare Data and Analytics at Green Mountain Care Board, and Katie McGraves-Lloyd, who was the lead analyst in the reporting project and is a senior health data analyst with Onpoint Health Data. So with that, let's toss it to Sarah and Katie.
Hello, my name is Sarah Lindberg. I work with the Green Mountain Care Board in Vermont, and today I'm joined by Katie McGraves-Lloyd, who is with Onpoint Health Data. We're here today to talk through a couple projects that we were involved with and are still involved with in some cases that have to include value-based and non-claims-based payments in trying to assess the investment associated with primary care. So I'll start off by talking with you about Vermont's all-payer model. This is a 5-year agreement between the state of Vermont and CMS. We're currently in the middle of it. And among its many goals, it includes financial targets where we are trying to review or limit the total cost of care growth on a per member basis for Vermont residents. And like a lot of payment reform models, the all-payer model is trying to think through ways that we can incentivize a movement toward value-based care away from fee-for-service based reimbursement. Claims in our traditional claims-based architecture is great for claims-based reimbursement. However, these non-claims and value-based payments don't always fit into such a tidy framework. And so things like global budgets, where a provider gets a fixed amount for a fixed period of time, or capitated payments, where a fixed prospective payment might cover a myriad of care for a identified beneficiary, And risk-based arrangements such as shared savings and losses aren't always captured very elegantly in a claims reference point. So in addition to those challenges and just getting the information, it also is a lot less detailed and granular than we're used to when we look at these non-claims based expenditures. So for the all-payer model, where we ran into it is that our all-payer total cost of care that we're measuring has two main components. The claims-based reimbursement we're able to get from VCures, our APCD here in Vermont, and then these non-claim-based expenditures, which we had to come up with different ways to collect directly from payers. And those include capitated payments that are made between the Vermont Medicaid program and the Accountable Care Organization, care coordination payments such as PCMH, CHT, and other population health payments, as well as the shared savings and losses realized by the ACO as part of the model. So for most of these payments, we've got a kind of very crude way to measure this on a per member basis, where we just take the spending in aggregate and distribute it through the full population. So using the Medicare shared savings in 2019 for the ACO, we just took the $11 million and spread it across the 1.5 million member months to add $7.63 on a per member per month basis. However, that's the way we had to start with Medicaid, but we were able to really change the game when we were linking the information for these payments to the eligibility data in the APCD. So with the partnership of Onpoint Health Data and our Medicaid agency, known as the Department of Vermont Health Access, we now can see at a very granular level the different behaviors and how there may or may not be differences in care patterns among those who are receiving these new and innovative capitated payments. That was huge for us. I'm going to turn it over to Katie to tell you a little bit about her project.
Great, thanks, Sarah. So I'm going to talk to you about the NESCO report on primary care spending, specifically how we incorporated non-claims payments. So the goal of this study was for the 6 New England states to use a standardized approach to identify the percentage of all payers spending. So the claims portion came from the 6 APCDs from the 6 states, but for the non-claims payments, we devised a collection template that we provided to each state representative, and they reached out to either specific insurers or their own internal databases. We were interested in collecting this information for each major payer, such as commercial, Medicaid, or Medicare. We collected a non-claims denominator, so the total non-claims expenditures, as well as the primary care numerator. This reporting was broken out by specific categories, which I'll go over on the following slides. So examples of such categories are capitated or salaried payments, risk-based reconciliation, patient-centered medical homes, PCMHs, or primary care homes, as well as performance-based payments, whether they're retrospective or prospective, health information technology investment, or workforce payments. So of the 6 New England states, 4 states provided commercial non-claims payments, 2 states provided Medicaid, and 1 state provided Medicare. Excluding the patient-centered medical home or PCMH category, it's not always clear what % of payments were directly used to support primary care practices. So we communicated with the states to help us better understand their data. For example, the Massachusetts analyst gave us a percentage to apply to specific non-claims categories to estimate the primary care spending. Here you can see there's great variation. Rhode Island shows the highest percentage of primary care at 85%, and Vermont shows the lowest at 57%. But this is biased by the fact that there's no standard method for collecting this information, and there's no standard definition for what constitutes primary care. So those definitions likely vary by state. So we were also interested in incorporating the non-claims payments into the % of primary care spending. So if you look at the bottom 3 rows at this table, you can see the % primary care payments from claims from the 6 APCDs. And then when we add in the non-claims payments, I think it's worth noting that the ranking of the states doesn't change here. So where Massachusetts is the highest at 10.9% from claims and then 15.4% when we add in non-claims, Vermont is the lowest, still 7% from claims and then 7.6% from both claims and non-claims. But again, the non-claims information is biased by the fact that there's no standard method for collection or no standard definitions for primary care or categories. So conclusions from both Sarah's work with the Vermont all-payer model and then the NESCO primary care work relate to developing standard data collection and categorization of non-claims payments. There is work currently being done to further this effort, such as the recently published Millbank report with recommendations on collecting and measuring non-claims payments for primary care. Additionally, we think it would be worthwhile to collect non-claims payments at an individual level, and this would allow for richer and more flexible research. So for example, if you had individual characteristics, that would help inform a specific research question. Sarah also has thoughts here.
Sure. Thanks, Katie. I would just add that as a regulator, we think a lot about the burden we're placing on regulated entities. And so to the extent that we can think about leveraging existing architecture and frameworks, I think that would be really beneficial to those participants in our data collection schemes. So APCDs, I think, would have a very potential big role in this, as well as potentially thinking through ways to extend something like the FHIR framework for trying to standardize this data collection. So if anyone is interested in taking a closer look at either things about the all-payer model here in Vermont, or the NESCO report, or the Millbank report that Katie discussed, please follow these links. And if you do have any additional questions or concerns, please do not hesitate to reach out. Thank you so much for your time.
Great, thanks so much, Sarah and Katie. And I think now we can transition to have a couple questions to follow up on that great presentation. And I'll kick things off with a very self-serving question. So right now in Virginia, we are going through the process of trying to put together a primary care spend report. We have a whole task force with it, and we're working on the methodology. We don't have any non-claims based payment data we're going to use. So what do you think? We're running this report whether we got the non-claims payment or not. So what do you think we need to watch out for, maybe that where we could be led astray, or something we need to keep in mind as a caveat by not having that non-claims based payment data that we need to build into the report to make sure that we're displaying it as accurate as we can?
So are you looking to collect the non-claims information, or you're saying you're not going to include it?
I'm saying we're going to produce this report and we will not have that. So I'm wondering, like, what element with that you think, when it's not there, do you think would be something we need to watch out for within the report? Like, essentially, what's the value add of the non-claims based payment?
I think in theory, the value add is that it gives you a true picture of the spending, right, from claims and non-claims. It also gives you those broader investments that, are not at a detailed claim level, like infrastructure investments, like HIT. But I did notice that in our NESCO study, it didn't change the ranking of the states, adding the non-claims value. So for example, the state with the highest percent primary care from claims was still the highest when we added in non-claims. I was saying with the lowest. So I think it would be ideal to collect it, but I don't think it may not necessarily change your result.
Great. And so we do have questions come through for both of you. How would an APCD collect non-claims based data at a member level?
I can take this one. It's a great question, and it doesn't always make sense. It depends on the type of non-claims based payment. And that's one of the enigmas I find about this space, is that where you measure the spend can really change what you're measuring. So are you talking about where the exchange happens, in our case, between the ACO and the payer, or post-settlement, once risk has been established and those risk arrangements sugar out? But in our case, we are dealing with a lot of prospective capitated payment arrangements, which is probably not a super common thing, but that's where payments, anytime they're made at a member level, I think could be collected through an APCD. I also think our primary care medical home and CHT payments often do connect to what I think of as a belly button. So that's part of why that framework I think is so important, like where you measure it, how you measure it, and what you're optimizing for.
Great. Let's see, another question. So Caitlin Sullivan wants to know, how are non-claims determined to be used for primary care services? Self-report from health plans or providers?
Yes, so basically, yes. So for the PCMH categories, we know that that's all primary care, but for other categories like retrospective based payments, that comes from the payer, but also we worked with the state representatives. So if the payer didn't have that specific information, a state would know their data and suggest, a percentage to apply. I think my final thought on this is that if you look at the Milbank report that just came out on collecting this information for primary care, in Appendix C, they have this template. It's a sample template to collect the information. And one of the recommendations in this report is to use a percentage, just like apply a percentage for specific categories. So if you open that, you could see what that work group proposed for percentages for specific categories.
Thanks. Another question that's occurred to me too. I mean, how difficult was this to get this non-claims based payment data from the plans? Like, did they have to do it? Was it pretty easy? Like, what was the give and take on that like?
Yeah, I think it depended on the relationships within the states. I mean, so of the 6 New England states, we got non-claims information for 4 of them. And a lot of the information was varied. I think it's, so to answer your question, I think it depends on the relationship that state representatives have with the payers on how easy or hard it is. But also, some states have this information already loaded, like at least for those large infrastructure investments. And so that doesn't really involve going to a payer, right? So if a state had a hard time getting the information from a payer, they might still be able to get some of those larger investments from their own data.
Right. No, thanks, Katie. And just because we're running low on time, one thing I'll just sort of paraphrase to ask, for the non-claims payment data, Sarah, is that like layout publicly available? Like if someone wanted to know exactly how you collected that and the specific elements, like is that out there? Where is there a place someone could go to review that?
So ours is really a financial file from the Department of Vermont Health Access, our Medicaid agency, but I am actively interested in cultivating a framework. I know that Katie has a layout of how they got the information for their study, but I think that would be swell if we could standardize that.
Right. Great. I think we're getting yanked on time. So Sarah and Katie, thanks so much for sharing your experience, and we'll have you back at the end for general questions as well. And so with that, I'm going to transition to our next couple of speakers who are going to talk about data standardization related to building a provider database that actually meets users' needs. And we have a couple speakers with us from HSRI. One is Leanne Candura, who oversees the implementation of multiple different state APCDs and related projects, and Melissa Hillmyer, who's a project manager at HSRI and leads the strategy for the MHDO provider database. So very looking forward very much to see what you all are working on or worked on at HSRI around provider database, and we'll hand it off to you.
Welcome to today's presentation, The Path to Building a Provider Database that Meets Users' Needs. I'm Melissa Hillmyer, a project manager at HSRI, and today I'm presenting along with Leanne Candura, the director of our population health team. Healthcare provider directories are often difficult to develop and maintain. National provider directories are frequently outdated, lack hierarchical context, and the information submitted to APCDs on health insurance claims, as well as the accompanying provider detail files, is challenging to work with across submitters. The objective of our presentation today is to share the approach that the Maine Health Data Organization, often known as MHDO, is taking to develop and sustain a provider database. Today, we'll highlight use cases, discuss data sources and technology implementation, as well as outline future directions, including state and federal opportunities to improve the quality, completeness, and accuracy of information for public benefit. In the state of Maine, information on healthcare providers, both facilities as well as person providers, was coming from multiple different data sources for several different projects, and there was a need to streamline that information. So MHDO is creating a go-to source of provider information in the state of Maine. MHDO is developing a provider database to support the management of healthcare information in a directory structure by collecting comprehensive and timely information on health systems, facilities, payers, and person providers in Maine. This includes both organizational information such as name, MPI, address, as well as the relationships between those providers. The data can be accessed as a standalone file or linked to other MHDO data files that include provider information. The MHDO provider database includes information on facility providers, including identity information, classifies information by primary taxonomy as defined by National Uniform Claim Committee, and also nests service locations within health systems and provider groups. The database currently has over 2,000 facility providers representing a number of different types, including clinics, hospitals, primary care practices, surgical centers, and behavioral health providers. The database also contains person providers, including their identity information. So again, name, address, MPI, classifies those person providers by provider type, specialties, credentials, demographics, as well as their service locations. And then the database creates a relationship between the facility provider as well as the person provider. A number of decisions needed to be made when we were developing the database structure. So each row within the database includes a unique row ID with either a unique MPI or a unique address. So for instance, if a facility has multiple MPIs, each of those MPIs would have a row within the database. Then the facility providers are also given a unique entity ID. And then parent facilities, which are either health systems, hospitals, or provider groups, have a unique parent ID. And then related facilities are connected based on that parent ID. Another decision point we had to make was in regards to taxonomy. So if multiple taxonomies exist, we're only using the primary taxonomy and validating on that. We've integrated geocoding into the provider database. And again, we've created relationships between facility providers and person providers based on both billing MPIs as well as rendering MPIs and claims from the APCD. There are several use cases that we have within the state of Maine. The first being Compare Maine, and that's the state's healthcare transparency website, which includes more than 300 facilities. And the provider profile page contains baseline organizational information, including name, address, website, allowing users to easily connect with a facility. MHDO is also required by law to collect organizational information and work with every health system, parent, and hospital in the state to update that information annually. The information was previously collected, but we've created a new data submission portal that allows hospitals and health systems and parents to more easily review, update, and validate their information, both their organizational information as well as physicians that are employed or affiliated with that particular facility. The Department of Health and Human Services is creating a service locator tool in the state to allow users to view the availability and capacity of behavioral health services and providers, including allowing users to book an appointment. And so the MHDO provider database contains more than 650 behavioral health providers, and data from the database is being used to pre-populate the service locator tool. We're also working with MaineCare on the provider API portion of the implementation of the CMS interoperability and patient access final rule. An API is a software connection that allows applications to talk with one another. And this particular API includes provider names, addresses, phones, specialty, as well as conforms with the ONC technical standards. Now I'm going to turn it over to my colleague, Leanne Candura.
Thank you, Melissa. That was a great overview of what we're trying to accomplish with our provider database. Next, I'm going to discuss what the initial data sources were that we built this off of and how we're using technology to accomplish our clients' use cases. There were 4 core data sources, each with its own pros and cons. The first was the CMS National Plan and Provider Enumeration System, or MPES, which provides the MPI, a key unique identifier with details about each facility and individual provider. The next data source was Maine's APCD. This data source allowed us to establish relationships between facility providers and person providers, but only covers providers who bill health insurance. Next, we also brought in information from Maine's state licensing for mental health and substance abuse services disorder program, which is comprehensive for behavioral health programs, but whose data are in non-standard formats that required more manual work to integrate. Finally, given our use case providing the provider API solution for main care services, we needed to integrate the full list of main care providers, which is comprehensive for claims billing purposes, but the data source did not adhere to our original database structure that required an MPI. Main care allows service types such as transportation providers, which are not required to have an MPI. Now that we've reviewed the original data sources, this slide provides the comprehensive diagram of how we then link all of that baseline information into a structure that allows us to serve and maintain the information for the use cases that Melissa discussed earlier. The hub of our system is the underlying MHDO provider database populated with the data sources we just reviewed, built out in HSRI's Verity Analytics. This hub then feeds into the other use cases. In order to provide the comprehensive information, we had to use the existing data to establish hierarchical relationships. We had some existing information that allowed us to make organizational links using Maine's hospital encounter data and Compare Maine, which also covers providers outside of health systems and hospitals. There was also a significant amount of manual review using web searches to establish the organizational links. But for person-provider relationships, we wrote a SQL program that used the APCD data to establish relationships of physicians to the facilities in which they practice or that they're affiliated. Finally, we had to establish ways to validate the information within the database. Annually, we use the Compare Maine update process to validate the over 300 facilities displayed on Compare Maine. And starting this year, we're using requirements under MHDO Chapter 300, which requires every hospital and health system to validate each entity within their system, including hospitals, physician practices, specialty practices, and primary care, along with each employed affiliated physician within the practice. Finally, we also receive a monthly feed from Maine's Medicaid program to ensure that we have the most up-to-date provider network information. Now, as I mentioned earlier, we are deploying our provider database in HSRI's Verity Analytics. The benefit of implementing the API within this platform is that it allows for additional opportunities to manage providers and add other modules to support provider-related work within the state of Maine. In order to support the Office of Main Care Services to meet the CMS interoperability and patient access final rule and in compliance with ONC's 21st Century Cures Act final rule, our first product that will be deployed under the provider directory will be the API, making the main care data available using HL7 standard on a FHIR database via a public-facing digital endpoint. FHIR, or Fast Healthcare Interoperability Resources, is an API-focused standard used to represent and exchange health information maintained by the Standards Development Organization HL7, or Health Level 7. A core goal of FHIR was to create a standard that would lead to high adoption across developer communities. It is focused on being easy for software developers to use, using common and widespread technologies, while also opening up development to individuals who do not have a healthcare background or expertise. Like many other components in the standard, FHIR uses modern security standards. So next, and finally, I want to touch on future directions for the provider directory. In order to maintain such a comprehensive database, we need to continue to rely on standard inputs and definitions. We then add in modern technologies to update and serve the information in a variety of formats that will allow different use cases to access, whether it be through an API, an interactive web tool, or a data extract. Finally, we must continue to update and validate the information to ensure it equates to a maintainable and high-quality database that can serve the use cases we've outlined with the potential for new opportunities. Back to the system diagram. In yellow, you will see the first product we've discussed, which is the Main Care Provider Directory API. HSRI will develop a maintenance schedule that will enable the API to be updated within 30 days of main care provider updates per the CMS interoperability requirements. These updates will be part of a broader maintenance and data governance plan being developed as part of MHDO's provider database activities, which includes supplying data for the Maine Behavioral Health Service Locator tool and data feeds for Chapter 300 updates and Compare Maine. Just heading back a slide, there we go. We are all excited about the future opportunities, including linking to Maine's APCD, hospital encounter, and other data sets. We would also like to bring other insurer network information, which could help with surprise billing analysis. Finally, the platform could include integrated dashboards and other reports to summarize the type of information in the MHDO provider database. It could utilize incoming APIs to populate and update provider information. It could also populate a front-end website with information from the MHDO provider database, allowing consumers to see where providers work and inform decisions when selecting health insurance plans. And finally, a set of recommendations that will help support our current and future use cases to make this a sustainable and maintainable resource. We would like to see the continued focus on common data layouts at the state and national level, the creation of new validation processes to improve the quality, more requirements for MPES information to be updated, and finally, a common model for provider hierarchies that support cross-state research and reporting. Broader adoption of the FHIR standard, which does have a format for these hierarchies, could support this. So I want to say thank you on behalf of the HSRI team who contributed to this effort, and also special thank you to Karen Lee Harrington at MHDO, who is the driving force behind these efforts within the state of Maine and for national standards. Thank you.
Great, thanks, Melissa and Leanne. I'm very envious of what you all have accomplished in Maine. That definitely seems like something that we need in Virginia. And we've gotten a fair number of questions. Just to segue before maybe the first one comes up. What was the genesis for doing this work? I mean, like, we all struggle with provider like standardization and registry, but like, what was the genesis for actually doing something this large of a scale for a project to try to fix it?
That's a great question, Kyle. So as you already mentioned, the questions around providers are numerous, and MHDO houses a lot of wonderful data assets, including our hospital encounter data and our APCD. And we have so many varied data users and a regular data user group. And through these groups, the constant questions that came up around, providers and how to, associate them with the different provider networks and also within hospitals and health systems. So over the years, we've had a variety of projects that sort of have layered on top of one another that has allowed us to get to the point where we are this year, with being able to bring in the use cases around the behavioral health locator tool, and then the directive around the API service needed that has helped create some additional resources to really create more of an investment in the state of Maine to enhance the information that we have. And, one of the things that we mentioned that was one of the key products that initially helped us do some of the provider work was Compare Maine. And because on the Compare Maine website, which is Maine's transparency website, we already had started some of the associations between hospital systems with the practices. And so we had already started some of that framework that then allowed us to keep building. And so because of all these opportunities and the great work that MHDO has done with connecting with other state agencies that had needs around this, that we were able to kind of bring all of these opportunities together and really start to build something that we want to be able to maintain because it's feeding so many other key activities.
Yeah, great, thank you. All right, there's no way we're going to get through all of them, but so Melissa, do providers other than hospitals need to submit information to MHDO to review the compiled information? And if so, how has that compliance been with that?
Yeah, so MHDO also has a mandate. It's called Chapter 300, and that requires both health systems and hospitals to review the information on an annual basis. And so in addition to just reviewing their own organizational information from the health system and hospital perspective, then it's also the hospital's responsibility to review any primary or specialty care practices, as well as their person providers that are employed or affiliated with those particular practices. And so again, that is an annual compliance. And we built a data submission portal to try and make it as easy as possible for representatives from those organizations to go ahead and log in. We pre-populated the information within the data submission portal from previous information that we had, that MHDO had from a previous rule chapter. And the compliance for this new Chapter 300 that we're doing in the state of Maine will be launching here shortly.
So Kenley's got a question. I'm curious about this too. What types of subject matter experts did you use to build and validate the hierarchy required to associate providers within locations, across locations, entities? And is that methodology available for review and reference?
Great. Great question, Kenley. So there's a lot of different associations that we have, but I'll focus first on what we use the APCD for was to connect the individual practitioners with the facilities in which we receive claims that they were associated with. And that was, custom coding that we did where HSRI as an organization love to share methodologies around how we put these data sets together. And so we would absolutely be open to sharing that information. A lot of the hierarchical structures around hospitals and health systems and their related facilities, we had that information from other work, but there was also a lot of manual web searches.
Makes sense. All right, I think we got one more question. And just to summarize this a bit for you, Melissa. So regarding the provider director API, who is, I guess, the intended audience for that? And is the idea it would be hidden or just tell us a little bit more about the API and who'd be using it?
So the API is part of the main care requirement for interoperability. And so that will be on main care's website and accessible to a number of data users, be it researchers or health analysts. And it is a federal requirement to make that API accessible. And so I think part of the use cases for how that API will be used are to come. I don't know, Leanne, if you have anything to add to that.
No, we look forward. I know a lot of states are just getting their required APIs for their provider and member work out into the wild, as we say. So I'm really excited to see how those are going to be used.
Great. Well, Melissa and Leanne, thanks so much for talking about the great work that you're doing, the provider directory in Maine, and I'm sure probably many other states to come in the future. And hang around for questions here at the end. And so let's transition to our third presentation to wrap things up around data standardization. And this is definitely a topic that, again, that many of us struggle with. It's untangling the mess of claims versioning and what they've learned in the state of Colorado with their all-payer claims database. So speaking on that, we have Julia Tremaroli with Civic, and she is the intake quality and policy analyst there. And presenting with her is someone else from HSRA, Katie Howard, who's the data scientist, project manager on the population health team. So Julie and Katie, pass it to you for your presentation.
Good afternoon, everybody. Today we're going to be talking about untangling the mess of claims versioning, lessons learned from the Colorado APCD. So before we dive in, we just want to do some introductions. So my name is Julia Tremaroli. I am the Intake Quality and Policy Analyst at the Center for Improving Value in Healthcare. Go ahead.
And I'm Katie Howard. I work at Human Services Research Institute. I manage the business rules and data warehouse quality for Civic.
Wonderful. So today what we're going to talk about is what is claims versioning. We'll talk about some challenges that we face with claim versioning. We'll talk about how we solve those problems and discuss some takeaways. So before we dive in, just want to touch on the Colorado APCD, what it is, the all-payer claims database. It represents the state's most comprehensive source of healthcare claims, insurance claims information. Civic, the Center for Improving Value in Healthcare, administrates this database. And HSRI, our wonderful data vendor, helps us make sure that the data is of high quality, and they do a lot of analysis with the data to make sure that we address health disparities and understand them. So what is claims versioning? Claim versioning represents a foundational process to ensure high quality, accurate data in an all-payer claims database. It's also the process by which a payer communicates any adjustments or adjudications of submitted claims. Accurate claims versioning should allow for the identification of reversed or denied claims and the best and final claim. And what we use is the ASC 12 standard. We also use for pharmacy claims the NCPDP standard. which we'll kind of go into in a second. So this is just an example of what this would look like. So just for those visual learners out there, this is how something might come through to us from the payer submitted data. So this top, hopefully you can see my mouse, this top box here goes through something that might have been submitted in January and then needed to be adjusted in February. So the Colorado APCD collects claims on a monthly basis. So it's important that we're able to make these adjustments because claims are dynamic. So in this case, a claim was submitted to us in January with a $90 paid amount from the payer. And as it turns out, they said, oh, we underpaid. We need to make an adjustment on this claim and change it to $110. So they use a good number of fields. There's quite a few fields actually that we use to make sure that this comes through correctly on our end. So after they issue that first claim, then in February, they will submit a reversal version of that claim, which is identified by the claim status code of 22. They communicate to us that this version number it's the more recent version number from the original version. And they fully reverse out, so they submit the inverse of the paid amounts on that claim and then unit amount as well. And then finally, they reissue the adjusted claim. So they just, instead of adding numbers or subtracting, it's just a complete replacement, and they submit the correct paid amount in the paid amount field. So what happens on our end is we take all those different versions and then we release this final version into the APCD based on what they've communicated to us through the different records that they submitted. So in this case, we have the $110 paid amount instead of the $90 paid amount, and everything's good. So some challenges, you saw that there's a lot of different fields that we use, and there's a whole process that needs to be followed, and sometimes payers do not follow that logic for whatever reason. Sometimes they might not assign consistent claim IDs, issue reversals, communicate the version number correctly. There's a whole host of different issues. Even the list that's on this slide is not fully comprehensive. There's a lot of different ways they might not follow the proper logic. And without following the logic, it might lead to duplicate claims, missing claims, duplicating claim lines, or potentially missing claim lines, maybe incorrect paid amounts. There's a whole host of different issues that could result from that. So to address it, Katie will take it from here.
Yeah, one of the most important parts of addressing claim versioning is really being proactive with clear communication, both between submitters in your organization and within your organization. We really try to create multiple points of communication through the data submission guide, trainings, and standard communication. This really gives the submitter the opportunity to tell you when their data are not in line with the standard, so you don't have to spend time trying to catch it in your quality check. Also, between our two organizations, we establish clear lines of responsibility for who is communicating with and how they are communicating with submitters. This really saves time and energy. And we also have a process for determining when we need a resubmission, to implement custom logic, or just leave the claims as is. With limited resources, there will always be a balance between the number and types of quality checks and what leads to higher quality data. This is something that we're constantly keeping in the back of our minds. There's really a sweet spot between too few checks and too many checks. So I'll go through 4 types of different domains that we use for our quality checks. First, we have the onboarding checks. And so this is when there's newly coming into the system. It involves all the standard checks, but more attention is given to the payer. Thresholds are lowered for identifying quality issues and when resubmissions are needed. And extra staff time is devoted to working with these onboarders. The second type of checks are intake validations. They're performed on key fields that are needed for claims versioning. And they look at how they also check the interaction between fields. So for example, The claim status code delineates when a claim line is a reversal. And in the validation check, then we would expect to see that for a reversal, the payment amounts on that claim line are not positive. With the next type of quality check post-processing, we run these when these quality reports after the data have been fully processed and the best and final claims have been identified. In these checks, it's important to decide not only what kind of quality check you want and how to check it, but also at what level of the data should you check it. How granular are your checks going to be? Line of business versus insurance product type code, month level versus submission period. We do recommend breaking out claim versioning checks by inpatient facility, outpatient facility, and professional claims, because often facility claim versioning issues are different than professional claim issues, even within the same submitter. We also further break out facility claims by inpatient and outpatient because, while inpatient facility claims are among the most important, the lower volume of claims can cause potential issues to be obscured by a higher volume of outpatient facility claims. The last type of checks we do is giving annual metrics of our fully processed data from the COA APCD to the data submitter for comparison within their own data warehouse. It's also important as part of this process to communicate what logic is being used to version their claims. You don't want to overwhelm the submitter with a lot of metrics, but you do want to concentrate on those highest value metrics. There are clear pro cons between each type of check. You can see that there is a progression between the length of time when a submitter provides the data versus when they get feedback for each type of quality check. The longer the amount of time between the submission and the quality check, the longer it'll take to address that claim versioning issue. So you want to balance that when you're using these quality checks. We find, however, that each level of checks is an important part of ensuring accurate claims versioning. This is a decision diagram of how we decide when to implement custom logic. We have a very long standard operating procedure document to establish clear roles and responsibilities between Civic, HSRI, and the submitter at each step. The final outcome of this process are displayed in the gray boxes. We may get a full resubmission that fixes the claim versioning issues. We may implement custom logic for the payer, or we might implement a hybrid approach. Incorporating checks at all stages of the quality process will allow you to catch a variety of issues. Implementing custom logic for submitters and figuring out what that logic needs to be can take a lot of time. And Civic is really working towards aligning their data submission guide with the national standards so that efficiencies can be found across states.
Exactly. So we really think it's important to establish that clear national standard for payers and states so we can collaborate if national payers need exceptions to the claim versioning process. So with that, here's our contact information. We thank you very much for joining our presentation, and we hope you enjoy the rest of NATO.
Great. Thanks, Julie and Katie, for that presentation. You clearly are on it when it comes to versioning in Colorado. So we've got some questions coming in, but just to, I'll selfishly pose one first. I mean, what's the response been from the plans for this? When you said we're going to do this with versioning, like, was there an uproar? I mean, how did it go?
I suppose it depends on who you'd be talking to. I think the plans at the end of the day understand how important it is to have accurate data. At the end of the day, you know, if we're going to produce a report on a named payer basis and it shows that they have twice as much spending as they actually do in real life because they're submitting duplicate claims, then that reflects poorly on them. So I think they understand it, but it's a lot of work. So it can be really complicated.
Let's see. So first question I see in the chat. So Hope Morrison wants to know, do you accept claim lines with negative quantity?
I can take this one, and Katie, let me know if I get it incorrectly, but Within the versioning process, negative quantity would indicate to us that it's a reversal version. So it would be the inverse of that original claim or whatever it's reversing out. So we do collect it and we want it to be negative, but if it's on a paid version of a claim, we wouldn't expect it to be a negative on the quantity field.
Katie, you concur? Anything you want to add to that? Or?
No, I think that's accurate. We do accept negatives in the units.
All right. Next question. Kenley wants to know, how many versioning approaches does Colorado currently support?
You can take that one, Katie.
I think maybe we're up to 10. I'm not sure. We really work with the payers so that they follow the data submission guide. Julia does a lot of interaction. For example, recently, I'll just brag on Julia. She really helped a submitter align with the data submission guide, whereas before it would have required a very high volume of code and trying to figure out what was the best and final claim. Julia was really able to work with the submitter to bring them in line with the DSG, and then we made a very slight adjustment to the standard logic. So that's where we really try to get people to the DSG so that we're sure that we're versioning across payers in the same way. And so that means that our comparisons are also valid across those payers.
Thanks, Katie.
Yep.
Yeah. Norm, I think I was getting the hook. We're down to a matter of seconds. Let's go ahead and bring the whole group back, I think, for broader discussion. And I guess those in the chat, I know we have not been able to address every question that's been posed, so we can always go back to those. But if anyone has any questions specifically where you'd want to hear from the broader group, I think that would be great as well if you want to plug those into the chat. And so to kick things off for the group, and maybe, we can start with Julia and Katie and kind of go in reverse order from the different presentations. I mean, so I'm curious, when we see these presentations, you all are doing just like great work in each of your different states. You look at it in retrospect, how long did it take to do this for your project? And how was that compared to how long you thought it was going to take? Like, I'm just curious, just for if someone wants to implement this, what are they getting themselves into?
I mean, it's claim versioning at the very least is a foundational process for data quality purposes. So you can't, from my opinion, I don't know how you would get away with not doing it, or at least having some sort of process in place. It's definitely a lot of work, but if you can front load the work with the payers and develop documentation, make sure that they fully understand what's expected, then it'll reduce the amount of time you'll have to be spending tracking them down again and saying, 3 years of data, this is garbage, we need to fix this. I don't know if you'd add anything to that, Katie.
I think you can expend as much time as you want. So that's where you're really balancing how much resources you have with the return on how much you're improving your data. But also it was funny, NADA's done this really great claim versioning series and aligning claim versioning in the CDL to establish that national standard. And Arkansas released a list of how they do it as part of that series. And I could go through their list and I was like, oh, I know who that payer is and that payer and that payer. So it seems like we're all trying to solve the issue in slightly different ways. And I think the CDL really offers that opportunity for especially those major national payers that we won't have to repeat the same work and we'll know how they submit their claims and what versioning they're using.
Great. Yep. So Melissa, Leanne, how about you? How was your experience compared to what you expected in terms of implementation of this?
Do you want me to start, Melissa, and then you can add?
Sure.
So provider work, again, can be sort of as big or as small as you'd like. And I think really being able to focus on the amount of resources that you have that can maintain whatever you build, because the second you put any provider information together, it's like obsolete, right? Physicians move, practices close. And I think a lot of work has been put in over the years by a variety of stakeholders for things that get used like maybe that year, they're useful. And then because not enough work has been put into what it would take to maintain that, the project sort of goes away. And so we really focused on creating ways and opportunities that could be maintained. There's either legislation that helps, there's other forces kind of happening that would help feed information into the provider database. But you also have to be very clear at what the database is and is not, because we always want more information, right? I would love to know like the office hours, the race and ethnicity of the staff who work there. And so there's all of these value adds that unless there is some external force that helps support the updating of that information, having it there once and correct once isn't going to give you a good product in the end. So I don't know if I really answered your question.
No,
but...
it's okay. I tried to come up with a question you could kind of take in any direction, you know, to kind of kick things off. So that's fair. Sarah and Katie, I guess any thoughts? I guess really what I would boil down my sort of long-winded question is say, like your expectation versus reality with the project. How do you think it went?
Do you want to, Sarah?
I feel like I'm spoiled in this case where it exceeded my expectations. I expected it to take years to get this done, but it actually came together pretty swiftly. So yeah, but the greater issue of if we're successful in value-based payment and when claims are kind of a stinky way to measure this stuff, like what's that data model look like where we have like clinical information, financial information, sorting out a source of truth? That's probably, you know, maybe I can get some headway on that before I retire.
All right. A question here from Doug McCarthy. So question for the panel. What are the current opportunities and challenges of using industry standards such as HL7 and FHIR for data collection by APCDs? Have these standards reached the stage of maturity that they can become the primary method for payer data submissions? So let's stay with you, Katie and Sarah. Any thoughts on that? I guess either for your project or just in general?
I'm not afraid to say something on this topic. So it's been on my to-do list forever to really take a deep dive on the HL7 standards for claims, and I have yet to really dedicate myself to that. But I do think it's an important thing to track in this space, especially as more and more payers are basically obligated to set up these APIs in accordance with the federal interoperability standards. I think it's going to be a really important mechanism that might increase the quality and value of that data and might, for us, for instance, get some low-hanging fruit that we've been dying to get, like premium information. So I do think it's a really important thing to track, especially thinking through future integration with clinical information. I think it's going to be a key pathway. So I haven't done my homework yet, but it's definitely one I'm actively interested in pursuing.
Great. Melissa and Leanne, any thoughts on the topic?
Yeah, I mean, it has been really great to start taking a deep dive and a very small sliver related to the providers to start getting kind of our heads wrapped around what this requirement is, what these standards are. And I would just say that I know that on the clinical side, there's been a lot more movement. I mean, there's a lot more requirements where they've had to use these standards. And I think until the payers are there, it's going to be harder for us and I'm speaking as like an APCD vendor to adopt, but I think the CDL is a nice mechanism where I've already seen some alignment of things that are in HL7 with the CDL, and I think making that connection and having these other opportunities where we can align is exactly the direction we need to go.
Great. Thanks, Leanne, and apologies. Julie and Katie, I don't think we have time to get your response, although I very much would like to hear it. But we had tons of questions. We didn't get to all of them. I really want to thank you all. Your presentations were awesome. You're doing incredible work. Like, very envious of what you all have going on across the country. I'm sure our audience has really enjoyed listening to it as well. So keep doing what you're doing and adding to the community across data standardization. And we look forward to seeing everyone throughout the rest of the conference. And I can't remember if there's something where you get to like rate your favorite session, but just think of this one when you do that. I found it very enjoyable. So, and I guess with that, Norm, I think we're right at time, right?